that things and have the 3D and more imaging and more understanding of the pathology, we could now understand the ratio of the AP and all of that. The challenges for the transcatheter valve is completely different. Anyone is interested, here is the reference for that one. The biggest thing, there's a lot of things: sizing, fixation, delivery, sealing, all of this taken into account, and it's on motion, and it's coming. So primary MR, there is lots of guidelines. Secondary MR, there is a few guidelines. Here is one of the messages that I want to deliver to everyone today is whenever you have a functional MR, please, please, please talk to your heart failure physician. They do have a different view of how they treat these patients in the future and current. And they will optimize them, and they do have a different set of management of that. Again here, annuloplasty technique, mitral leaflet, mitral valve replacement, cordial implants. A poor valve has been shredded between all the people. Recommendation: medical management, CRTD, see how things will go, and then after that you entertain other things. For the patient I have a better one than this one. Okay, secondary mitral regurg, optimal medical management, please, heart failure specialist to be there. Severe MR, EF is 50%. Then we go undergoing CABG, then mitral valve have to be done. And we will not go into that. It's a big subject. We had some discussion about it now. If the EF is more than 50%, severe persistent symptoms with optimal therapy and good control of AFib, then mitral valve surgery. If it is less than 50% persistent symptoms and the mitral anatomy is favorable or non-favorable, either mitral valve surgery or transcatheter edge-to-edge repair. This summarizes the things about it. So after that, it's to my main talk now, and I will concentrate on 2 points only for the surgeon about addressing the mitral valve, the functional mitral valve. So the minimal invasive, it's a growing thing. It's happening. If you have only functional mitral valve repair, please don't consider the annulus. Please have a good look with the imaging. Understand the valve pathology, understand what's undergoing there. Is it LV? Is it due to atrium? And if it is due to the LV, then you have to add another thing to your mitral annular downsizing, which is you have to address the papillary muscle, you have to address the LV. There is multiple ways of that one. The major one that I do always in all of my patients is having both papillary muscle together and bring them. For the surgeon, this is the posterior mitral papillary muscle. I just put the stitches in there in the Gore-Tex with the Bludgeoned, and then I bring it through the annulus. After I put my annular stitches, I bring it through the annular mitral valve. That's one of the procedures that I do. The other one that I consider it is to bring both papillary muscle together. Unfortunately, the video did not work for the first one. The second one, it works, but I have to take it with my phone. So here is what I do always in all patients who is just only functional mitral valve. This is the anteropapillary muscle. This is the posterior papillary muscle. And then I start with putting the Gore-Tex in the papillary muscle down in the LV. After we put the stitches there, it is a pre-made, pre-noted with the Bludgeoned Gore-Tex. Put it in the anterior mitral leaflet, anterior papillary muscle. And then I put another one in the other posterior medial papillary muscle, as you can see here. And then we bring both of them together. So the LV, instead of, if it is big, we just only bring it together. And then we put the annuloplasty ring. And and you could use anything available on the shelf, either a Proline if there is no Gore-Tex sutures. I find the most difficult one after you place this one. I learned the trick from Profum Zebra is having the needle facing you when you put it in the papillary muscle. Surgeons, they will understand that one. And then you hunt your previous pre-made knot and you tie it together. You see that one down in the LV? And you put the needle through that one and you tie them. By that way, you will bring both papillary muscle together, bring the LV smaller, and that will prevent the recurrence of the mitral regurg after. I think we tend to forget this one a lot as surgeons, or maybe we don't forget it, we just try to forget it because it's add around other 5 minutes, 10 minutes, 10 minutes maybe. So I bring the stitches through the annulus before I put my annular stitches, and then I put the annular stitches and put the ring in there, and then I tie it to the ring. What's that? Yeah, and this is the saline test afterward. And then I tie it to the ring itself. So in conclusion, there is a high prevalence of untreated moderate to severe mitral disease, unmet need. Recurrent mitral regurg post-time VR exceeds still transcatheter valve, still significant. Minimal invasive mitral valve repair. Address the subannular apparatus and its promising solution. Mind you, even in a transcatheter valve, they start to address this one. And this one is not comparable between the transcatheter mitral valve replacement and repair. Thank you.